I consciously did not look at my phone to see what you tweeted, so I'll save that for... thank you, David. That was great. A few months ago, I made my way across the Duke University campus where I work to find the office of Amy Abernathy, MD. Dr. Abernathy is a medical oncologist and a tenured associate professor in Duke Schools of Medicine and Nursing. Among her long list of titles and roles, she's director of the Center for Learning Healthcare in the Duke Clinical Research Institute, also director of the Duke Cancer Care Research Program, as well as co-chair of the NIH-funded Palliative Care Research Cooperative Group and president-elect of the American Academy of Hospice and Palliative Medicine. With more than 280 publications, she is an internationally recognized expert in health services research and delivery in patient-centered cancer care, especially pain, symptom management, and palliative care. When I walked into her office, she had just ended a conference call with a committee at the White House. I had asked for 15 minutes of her time, and I ended up staying for about an hour, listening as she shared her story. Medical training, residency, and fellowship in hematology and oncology at Duke University, then a palliative care fellowship in Australia, where she gained an interesting perspective on how the practice of medicine can improve, and improve faster. But she had me at, I write my own computer code. What she's up to, I came to learn, is an intriguing hack of the healthcare system, and we've asked her to tell us about that this morning. Amy?
ScienceOnline. Wow. So I am incredibly honored and humbled to be here with you today. I'm thankful to Anton, to Bora, to Karen, and sort of the ideas of all of you as you help us shape how we're going to take care of people in the future. You've just heard I'm a medical oncologist and a palliative care doctor. I'm a clinical trialist, so I think about doing clinical research in order to identify new drugs, treatments, interventions to take better care of people today as well as take care of people in the future. And like all of you, I'm a member of humanity. I'm a mom, I'm a wife, I'm a friend, I'm a girl who tries to jog but doesn't do very well. I'm a girl who likes a glass of wine on a Friday night. And it's within the context of being here as both a scientist as well as a member of the community of life that I want to talk to you about something that has been intriguing me for a while now. And I was sort of thinking this morning that much to Anton's chagrin, I'm going to pressure test this on you and talk to you about this concept that I call treasures. Treasures. So when I think about treasures, sometimes it's rubies and diamonds and emeralds and sapphires. Maybe it's pirate booty. Perhaps it's a treasured friend. Or maybe I treasure you. So if we look at the Oxford Dictionary, they remind us that in the context of being a noun, a treasure is something precious. In the context of being a verb, we hold our treasure sacred. And so it's within that context of being a treasure that I want to tell you 3 stories and identify some hidden treasures. So the first story is in my melanoma clinic. Remember, I'm a medical oncologist, and the people that I take care of within the context of cancer care are people with metastatic melanoma. So this is melanoma, a skin cancer that's spread, which for the most part is still a devastating and fatal disease. We've had a number of new treatments that have helped to lengthen the life of people with melanoma, in particular metastatic melanoma, but we're still waiting for that breakthrough and that cure. Many of my patients are young, and they're suffering great symptoms as a result of their melanoma, as well as trying to figure out what it means within the context of their lives, and we're always looking for the new drug. So in the melanoma clinic, we often have a series of clinical trials ongoing where we're studying new drugs and doing so within the context of clinical research. And you can imagine that one of those usual ongoing clinical trials, not thinking much about it, I was very excited about this drug because it had sort of an interesting immunologic mechanism. It seemed to make great sense. And we brought it as a multi-site study, and Duke was one of the sites in the study. And I enrolled a number of patients, as you do. And when you enroll a patient in a trial, the patient signs the consent form, basically signs up to participate. And in signing the consent form, you acknowledge that you're going to be involved in a number of things. So together, we're going to be studying this drug. So you're going to get the medicine, and we don't necessarily know if it's going to help you or not. And as a patient signing the consent form, you recognize that we don't know anything about whether or not there's toxic effects from this drug. But you also sign up to come back and forth to the doctor more frequently than you normally would, to lay down on the CT scanner more times than you normally would get CT scans, get more radiation. You sign up to get lots of blood drawn, and you sign up to fill out lots of forms and surveys and have people collect information about you. So I signed up a number of patients, people who participated in that trial. After all of my patients had finished, I hadn't really had any more patients on the trial for a little while, but we were still looking for the next one. And I got this phone call from the drug company who had been doing that study. And they said, "I'd like to let you know, Dr. Abernathy, halt all activities. We've canceled the study. We've canceled the development of that drug and that research program. All done, kaput." I said, wait a second. Well, are you going to publish the results? What are we going to do with all those data? And the person who talked to me on the phone couldn't tell me, said, "No, we're not doing anything more." And that was the end of the conversation. And I nor my patients never found out what happened next. As far as we know, the case report forms where all the data were collected were thrown in the trash, or the database on the server somewhere was erased. But either way, that was the end of the story. The second story. That first one was a couple years ago. The second one's 2 weeks ago. Sitting in my office with a mentoring meeting with a beautiful, wonderful junior investigator. We'll call him Mike. He is an exercise physiologist starting out on his career, interested in thinking about how we might predict which cancer patients would do better with exercise, where exercise might reduce the risk of their cancer coming back and help them survive longer. And he's trying to develop a blood test so we can predict which patients should get exercise as an intervention. Great question. So he's in my office trying to get my permission for a study he's planning, where he's going to have patients draw some blood, and then they're going to get on a treadmill every couple weeks, and then after doing their exercise program, he's going to follow what happens to their cancer and follow what happens to their survival. Makes good sense, and I can understand his study and his plans, and the biomarker that he plans to study makes good sense. But what was interesting to me is I said, Mike, I think I can save you a lot of time because Dr. King down the hall is doing something quite similar, and I'm pretty sure that Dr. King has got the blood drawn from those patients too. So why don't you use the blood from those patients, and then you can use the data from what's happened in Dr. King's study to do something similar to what you've already been planning. And Mike says, I already talked to Dr. King, and we all really respect him because Dr. King's a really good guy. He's a good friend of mine. And but Dr. King's told me that he really doesn't want to contribute the blood to my study or the data to my study until after his main results are published because he doesn't want to be scooped. And he's told me it's going to take a couple of years, but once those couple of years happen, then he's very happy to give me the blood. But, Mike says to me, Amy, I really can't afford a couple of years. I got to get my career started. So could you sign up for this study that I've asked you to do? I said no. Now, we accelerate forward not 2 weeks ago, but 2 days ago. Just like all of you, I was watching my email. It's going on by. And in my email, one investigator, we'll call him Sam in the United States, is talking to another investigator, we'll call him Charlie around the world. And Sam says to Charlie, hey, Charlie, I'm working on this grant application to the NIH, and I need some data to do a sample size calculation to figure out how big my study can be. Remember that study back in 1996 we did of morphine? Could you send me your data set so I can calculate what my sample size calculation should be? Charlie says, yeah, sure, I'll send you the data set. And I'm watching in my email as the data set comes along. And then Sam says, hey, wait a second, can you send me the password? I can't get in. And the password floats along. I'm watching this go by. And I'm thinking to myself, well, in 1996, we didn't necessarily have the same safeguards as we do today. I happen to know this data set really well. And it includes in the same data file people's names, addresses, dates of birth, their illnesses, as well as how they did on the study. So now what I'm going to do is spin the Rubik's Cube. What I'd like to do is look at the other side of the elephant. And I'd like you to venture back with me, to my clinic. Let's go back to story one in that clinical trial. I'd like you to meet Janet. So you have to see her. She's got red hair. She's 32. She's a nurse in the emergency room, and she's always wearing scrubs. And Janet had a melanoma on her arm. It was a melanoma. When it got removed, it turned out she had some lymph nodes underneath her arm. And she ended up having what we would call or characterize as 3B melanoma. This is what I call the 50-50 disease. The sad reality is that at 5 years, half of people will be alive who have 3B melanoma. Also, Janet with her red hair, her Irish descent, her mother died of melanoma. Her sisters also got red hair. So Janet's a healthcare provider. She understands the uncertainty. We have some long conversations in the clinic, and sure enough, she signs the consent form. You can imagine her dismay when she finds out the study's been discontinued for reasons that we don't really know, and that the case report forms are probably gone, and that her information isn't going to contribute either within the context of this study or any other research to the care of her sister or other people in the future. Story 2. So, as I said, Dr. King is a good friend of mine, and he does amazing research. And he's signed up Carl to be in his research study. So Carl is a 79-year-old gentleman with kidney cancer. And he's got a wife. Her name's Judy. And Carl's not very big. He's pretty frail these days, about 105 pounds. And you can imagine that Dr. King has signed him up to a study where he gives blood, and then Judy drives him to the exercise facility, and he kind of hobbles along, and he gets up on his treadmill, and he does his exercise to the best as he can. He was a physicist by background, Carl was, and so he actually recognizes that maybe this won't do anything different for my life, but I'd like to make sure that I'm also contributing to science. And so he's up on that treadmill, and Judy's driving him each week, and his blood is in the freezer. And that was Dr. King's study. I wonder what Carl would say if he found out we were going to hold on to that blood in the freezer for a few years because we want to make sure that the primary results don't get scooped before we do my study. And finally, I sort of shake my head in dismay as I watch those data go by in story 3, which literally did just take place 2 days ago, where it was really very well-meaning investigators wanting to work together, but forgetting the reality of the patient data that was contributed as a part of that study. So as I kind of start to reframe this for you, I want to make sure that you understand one thing. This is not a shame on you discussion. I hate shame on you discussions. So instead, I'd like to travel back to the concept of treasures. And I submit to you that one of the greatest treasures in science is the information that's in front of us. And that patients bequeath to us, when they're involved in clinical research, that information and expect us to use it in a way that contributes to today and tomorrow as treasured information. And if we treat their information like a treasure, it helps us find a way forward and understand what to do better. And so what happens when we treat people's information like a treasure, when we hold it sacred and precious? Well, the first thing we do is we keep it safe. It becomes much easier to tolerate regulations like security and privacy when we see them as safeguards that help keep people's information safe, as opposed to annoying regulations and other things that are just basically in our way of doing good science. And so I actually submit that part of our task as researchers is to pay attention to those safeguards because we would want the same thing to happen for us. The second thing is that when we treasure something, we think carefully about it and use it well and use it often. So, for example, in the story of Janet and her participation in that first study, we don't dump data. We don't discontinue the study and then never think about how to use it again in the future, but rather we always think about how to reuse that information over and over again. The second is that we remember as researchers, it's not about us, but it's about how the science that we're supposed to be doing is contributing to humanity on a bigger scale. And so if we think about it that way, it's our responsibility as scientists to quickly transition data to new knowledge. Instead of hoarding data, and so we're not scooped, we develop authorship agreements that say whoever gets to the answer to the question first gets it published. And that's because it's good for us all. And then finally, we think about the fact that we can use the same data point twice. Data is something that can be copied and used over and over again. And if we reuse what we have, then Carl doesn't have to get on the treadmill again. But rather, Carl's input into research is input for now and in the future. And so my point is that if we frame the way that we think about people's information differently, we find a way forward, and we see personal data as a treasure. And if we created it within the context of a clinical trial, then it was a treasure that was generated with extra hardship, and we respect that hardship and figure out how to do it better. And so some ideas of how things might be in the future. So one is that patients might have control of their information and be able to decide how it gets used, where, and when. You can imagine that when you put your treasure in a safety deposit box at the bank, if you don't like how the bank's using or managing your stuff in the safety deposit box, you switch banks. Or because data can be copied over and over again, you might have the same treasure in multiple safety deposit boxes and make sure that multiple different investigators all get to use your information well. The second is that we're going to see more and more in the future data sharing activities. Pooling resources to discover as much from every bit of information that we've got in front of us. Cancer patients are often surprised when I tell them that the information from this particular clinical trial is only going to be used for this clinical trial and won't be used again in the future, because they expect that they're contributing now and in the future. And so I applaud initiatives that are going on right now, like Project DataSphere from the Cancer CEO Roundtable, where industry and academia and federally funded clinical trials are actually all getting dumped into one place with open access to researchers to allow them to use it. And basically, the first person who finds the answer to a particular question within those data gets to publish it. In 2003, the NIH said the data sharing needed to happen for every federally funded clinical trial, but it's still hard to figure out how to do it, and part of our task is to make it easier. And then finally, if you get stuck, if you get frustrated by all of those rules about keeping information safe, or trying to figure out whether or not I should do this trial when it's already been done before, if we go back to remembering the context of the information that we've got to use in front of us has been generated by people who've done so with the concept of treasures and bequeathing to us their information from the future, it'll help us find a way forward. So, thank you.